giant of limitless power at man's command. And where was it science found that giant? In the atom, a particle so infinitely small that it takes over 100 billion atoms to make up the head of a pin.
This is Out of the Basement, a podcast dedicated to radiation medicine.
This is Dr. Jason Becktus celebrating what feels like Groundhog's Day down here in the Vermont Mountain Basements with a version of the same script in what appears to be a different year. Who even knows? But about a week before I'm recording this, I got texted a link to an ASTRO blog post from February 25th, 2025 entitled Radiation Oncology Reimbursement Could Face Major Changes in 2026. And the two words that are doing an awful lot of work in that title are could and change. I would argue we might consider will and gutting cuts, but maybe I don't know. That's actually what this is all about. I read the blog post and thought to myself, I feel like we've been here before and that none of this is really breaking news. It's more of a slow motion car crash that we've been both watching and participating in for many years. And let's unpack that a bit with some of our old favorites, such as Legacy, Professional Society, Unforced Errors, and some new things like a strange survey from the AMA that we got left out of. And we can consider all this as we head towards the edge of a cliff if we're in a slow motion car crash, Ridley's going to go with a fun car. We're going to go with a 1993 Chevrolet Cavalier stick shift turquoise blue that may or may not have been my first car. That's what we're going in towards the edge here. And before we get into all this, because a lot of this is quite confusing, I figured it would be worth revisiting our fundamental and incredibly bizarre Byzantine confusing system of medicine and Medicare, and specifically how we get paid, more or less. So you've got some key players in this. We have Medicare, of course, and you have our friends, definitely not the mafia, the American Medical Association, or AMA, definitely not the government mafia, Centers for Medicare and Medicaid Services, or CMS, and a committee under the umbrella of the AMA, the Relative Value Scale Update Committee, or RUC. And here's how they all, quote unquote, work together. Work's doing a lot of work there, but it starts with the AMA's current procedural terminology, or CPT codes, which are 5-digit labels for medical services like 99213 for a short office visit, or 47562, I think, for gallbladder surgery. I forgot to cross-check that, so hopefully that's right. I don't do gallbladder surgery, but there is somewhere north of 10,000 RVU codes, CPT codes. Whew, look, even I'm confused. Over 10,000 CPT codes exist, which are updated quarterly by the AMA's 21-member CPT editorial panel, which reflect new practices. Then when we, the physicians, or whoever's doing the coding here, are doing stuff, we assign these codes to Medicare claims, which CMS processes. So if I see a patient follow-up in clinic and I drop 99213 and submit it to Medicare, that's kind of how that works. So, but then what does that mean? What does 99213 get valued at? So that's where we have the relative value units, or RVUs, which measure any service's value in three parts. You have the work RVU for the physician effort, the practice expense RVU for overhead, and malpractice RVU for insurance. And you sum all those together. So spitballing, I really didn't feel like getting out and checking all my numbers here. So these are ish, but for a WRVU, or the physician effort, for 99213, you could say is 1.67. the practice expense is 1.18, and malpractice RVU is 0.10. So you could get a total of 2.95 RVUs for 99213. Nobody checked me on that. I don't know if that's right or not. Actually, everybody checked me on that, but it's somewhere around there. So then you have the RUC, the 31-member AMA committee, which is dominated by specialists and only a certain subset of specialists who are setting these values. The RUC meets 3 times a year in closed sessions. They survey physicians allegedly on procedure demands, analyze data, recommend RVUs. And that's by recommend RVUs, what I mean is they will submit a report or submit these recommendations to CMS, which may or may not implement those changes. And so that's the very interesting thing, is that only the AMA gets to come up with CPT codes, and only the AMA gets to come up with these RVU values for the CPT codes they get to come up with. And they give that to CMS, but CMS is not legally obligated to listen to them at all. Now, most of the time they do accept these recommendations, but it's gotten choppier over the last decade or so. So in the beginning, when this all started in the early 90s, it was somewhere north of 90%, 95% adoption of the recommendations. And then I think it was in the middle 20-teens here, somewhere around the 2013, 2014 era, they kind of fell off. So I think there was one year in there where they only took like 70, 75% of the recommendations. So that's my favorite. I'm going to say that a lot sarcastically this whole time. This is my favorite part about this whole thing, where ultimately the AMA could craft the most perfect recommendations and CMS could then totally ignore it with no consequences. That's just how the system is designed. But the payment for those RVUs, so let's say you've got your CPT codes and you've got the RVUs for those CPT codes, and then you got physicians submitting those. How are you turning those CPT codes into cold hard cash? And that is where you are multiplying the RVUs by the Medicare conversion factors, which is set annually. I mean, it's kind of always been about the same. I'll guess like $34.50 for 2025. So if you submit a CPT code, again, assuming 99213 is 2.95 RVUs, you submit that with a conversion factor of $34.50. That means that your office visit was valued and paid at $101.78. And then there's a geographic practice cost index, or GPCI, which adjusts this reimbursement for regional costs. So if you're in a high cost of living area, maybe it's $110 for San Francisco, maybe it's down to $95 in rural Kansas. See, there's a reason I chose to go over all this again up front. Everyone forgets about the GPCI, myself included. And then you have Medicare is covering 80% of that allowed charge, and patients or supplemental insurance are then responsible for the remaining 20%. You confused yet? Great. There's a lot of flaws. I think we can all identify several just listening to me ramble like that. But you have the system with 10,000 plus codes. They're prone to errors and are pretty complex. How the RUC works is opaque. It's kind of actually what this whole episode's about. You have a subset of specialists that are predominantly represented in this group, and it undervalues primary care, or in our case, totally just decides to steamroll how to value something. And you have RVUs that are ignoring changes in how medicine is done, either efficiencies or inefficiencies or inflation. Then the conversion factor, which is constrained by congressional budget rules, lags practice costs. That's putting it mildly. And the GPCI, the geographic adjustment, is based on old data and doesn't necessarily reflect current regional economics. And even though they can choose to ignore it, they usually don't. So the CMS just accepting what the RUC tells them, which then gets gobbled up by private insurers, is a weirdly, not to use the communist word of centralized planning, but mirrors that sort of centralized planning of we set the prices, we set what even you can charge for, you can accept it or you can accept it. And if you make a mistake, we can do some weird back of the envelope math and claw back millions of dollars based on an audit of 10 charts. But so that's kind of just a nutshell. CPT, RVU, conversion factors, RUC, blah, blah, blah. You get it. It's easy to throw stones at. It's a complicated system, but I felt like it was fairly important to review all those broad points. Are you confused yet? Great. Me too. I kept going back and forth on which points to hit in what order on this episode, so let's just go with the most bizarre aspect that has the most clear and tangible paper trail. So that would be the AMA's Physician Practice Information, or PPI survey, which was rolled out in 2024 by an independent outside agency or company called Mathematica, and it was supposed to modernize Medicare's practice expense, or PE data, which had last been refreshed in 2007 and is intended to capture the real costs of running a practice of medicine today in the here and now, which, all right, reasonable, I guess, reasonable goal. Unfortunately for those of us who practice radiation medicine, instead of an updated and precise number, we got a sledgehammer or ham fists, or insert other funny joke here. The survey, well, not the survey itself, but the fine folks at Mathematica and the AMA bundled radiation oncology in with radiology, which is what they did also to nuclear medicine and interventional radiology, which spit out a radiology PE per hour rate of $176.91, which is 40% below our current rate. And let's compare that to, I don't know, cardiology, $209.55 with, I don't know, stethoscopes. What is cardiology's most expensive thing? Maybe do they get to count echo? Maybe. It's hard to rationalize cardiology having a higher PE per hour rate than us, but you get dermatology, $250.46, because those skin creams aren't cheap, or ophthalmology, which is $297.19. Now that makes sense. They use those like eyeball laser things. They literally spot weld retinas back off with lasers. No notes on opto's hourly rate. That seems about right to me. But at least as it pertains to us, cutting our hourly rate 40% to $176.91, that's pretty unbelievable for a specialty that relies on multi-million-dollar technology and sprawling teams. That's absurd. I'm going to go with absurd. While I'm sure many of the audience of this podcast understands why it's absurd, just to spell that out, and it's more of a complete misunderstanding of what goes on here. We're not radiation oncology, radiation medicine isn't just diagnostic radiology's cousin. We're an entirely different beast. A single linear accelerator costs, it varies, but at least $4 million with your varying true beams or electivverses, and you have maintenance service contracts running. I know numbers because we're doing this right now at my hospital, but in the interest of not getting sued, I won't say precise numbers, but we're going to say several $100,000 for things like service contracts and ARIA licenses or Mosaic or Pinnacle or Ray Station, or, and then you got Breaky units, which would be, $500,000. You got shielding in the vaults, one or 2 million, plopping shielding in vaults, and other sort of fun, complicated Monte Carlo algorithm producing platforms. Now, that's not to besmirch diagnostic radiology. They have expensive equipment too. They're not running just stethoscopes and scalpels, and you got MRIs and CT scanners, which are pricey, but they're not Linac pricey. And if you can actually go look up what buying a new CT scanner would cost. You can get one of those for maybe $500,000, $600,000. But the bigger difference is those costs are spread across high volume imaging. There's an opportunity cost to radiation oncology where if you're dropping $4 million on one Linac you can only do one patient at a time. And if you're good, it's going to take you at least 15 minutes. If you're good, you could doing 4 patients an hour. And I don't know if y'all have seen what radiology is capable of doing, but it's a lot faster than that. So there's an opportunity cost that factors into our specialty that they don't have to worry about. And yeah, we don't get that nice buffer. Then you've got staffing, which again, recognizing that I don't mean to belittle diagnostic rads is not my point here. It's apples and oranges. They're both round fruits, but they are not the same. So for us, not only do we have our radiation oncologists, but we've got medical physicists, which generally we need a higher concentration, we'll say, of medical physicists, dosimetrists, which radiology doesn't have. We have special therapists, so do they, but they're, again, a different type of therapist. They go through different training. They do different things. And nurses, which we have generally more nurses than a diagnostic department. Sometimes there are exceptions to that rule, but on average. And you've got this entire crew that has much more one-on-one or more intense per capita patient interaction. The single prostate VMAT plan isn't just a quick show up, scan, go home sort of thing. It's weeks of scanning and planning and then actually delivering the treatment. And there's just a much leaner sort of business model you see with radiology that we can't access. And by just literally throwing us in with radiology, it completely dilutes and ignores reality and average this PE hourly cost down to basically a fiction that will starve us when and if it hits the 2026 Medicare physician fee schedule, and which is where those fancy RVUs are being put, lower PE. So that's in that math of in those components of an RVU value, lower practice expense data means each code drops the value of each RVU, which means less ability to keep the lights on. But it doesn't stop there, boys and girls, because we also have CPT code chaos. So in the 2024 or the published 2024 AMA CPT editorial panel recommendations, and this meeting was their third meeting of the year and it was published publicly on October 16th, but the meeting was from September in 2024. They recommend consolidating treatment delivery code 77402, 77407, and 77412, which are simple, intermediate, and complex codes for greater than 1 MeV beam energy into a vague new structure. So it's not clear. This is part of the whole opaque, secret Illuminati, definitely not mafia AMA thing they're doing. The ASTRO blog quotes what the RUC put out, which is these are being revised to consolidate and clarify, with the details TBD, I guess. But more importantly, they are recommending deleting 77014, which is CT guidance for field placement, or IGRT, and then 77385 and 77386, which is IMRT delivery, simple and complex. Those aren't exactly fringe codes. Those are sort of perhaps bread and butter code. And as we all should presumably know, for those of us in this field, those are pretty core treatment delivery codes. And nixing those codes doesn't simplify. It erases our ability to bill for complexity. And the AMA dropped this bombshell, or the RUC panel dropped this bombshell on October 16th, 2024. We didn't find out about the PE update until February 15th, 2025. Yet the ASTRO blog about both of these things was only published on February 25th, 2025. That's a head scratcher, to put it mildly. So while the AMA's RUC forged this flawed data into recommendations for the CMS 2026 rate, what was our legacy professional society doing in 2024? Our self-proclaimed champion. Were they tilting windmills? I think they were tilting windmills. In 2024, they were fixated on two shiny objects. The first being in-person supervision rules, and the second being my favorite, the radiation oncology case rate, or ROCR legislation. Both ate time, both flopped, and neither seemed to have any effect on the reimbursement freight train. To recap what I'm talking about, in the first half or early on in 2024, ASTRO came out of left field with a letter to CMS demanding that they revert radiation codes back to direct supervision, with the radiation oncologists required to be physically present each and every second the linear accelerator is on, framed in a patient safety argument. And as always, I am obligated, because I believe this actually to be true, to say that the intent here was noble. And I will just keep repeating this. I do think that everyone's heart is in the right place. There's no evil genius Illuminati plan going on here to intentionally do any harm. In fact, I would argue the opposite. I do think that the people involved in all this are trying to make things better. And it's always the age-old saying of, we judge ourselves by our intention, others by their actions. And I'm going to go ahead and I try to judge people by both. So the actions were not good, but the intentions were good, in my opinion. You can disagree with me, but and I've covered supervision at great length in various formats, but just to recap that, since January 1st, 2020, pre-pandemic, CMS switched codes to general supervision, which means that things can be done under the direction of a supervising physician, but that supervising physician does not have to be physically in the vicinity. They never did define that. Palmetto, which is a silly contractor for Medicare, tried to pull shenanigans about defining time, but that blew up in their face. That's a story for another time. I think I covered that in the past. I don't know. It all blends together now. But the January 1st, 2020 general supervision, and then we had the public health emergency with the pandemic starting in March, April 2020, which brought us the concept of virtual direct supervision. And all of this had run without any issue to anyone's knowledge up until this letter was submitted in early 2024. And zero data has ever showed harm, or no sentinel events tied to anything to do with this. And ASTRO decided to bring this up anyway, and boy, did that backfire. Wow. Well, I think we can all agree that we haven't seen backlash like that in a long time, maybe ever. There were many people who had brought up basically exactly what I'm saying. We've been doing this for 4 years. It's now 5 years as I'm recording this, but 4 years at the time without issue. We have kind of systems built around this. And what are you doing? So yeah, if you're a new resident, if you're PGY2 listening to this, you missed out. It's probably good you missed out. It wasn't great. It wasn't a pretty look, but in the end, CMS didn't care at all about this. And as I predicted, as many people predicted, they just extended the direct virtual supervision rules at least through December 31st, 2025, because they don't want to make a decision on this, so they keep just extending it. But that's for all of us. This is the entire house of medicine, not just us. But so they just said direct virtual supervision's okay through at least December 31st, 2025. And most interestingly, they decided to also keep virtual on-treatment visits, or OTVs, as provisional, meaning that they were not willing to take it away, like was what ASTRO asked for. They weren't willing to make a concrete statement either way. In the end, there was a lot of burned goodwill and burned political capital from doing that. And worse, it was totally irrelevant to these 2026 cuts to PE and the CPT code changes. Even a win here wouldn't have fixed those two things. Why do this at all? So this is where I get into my own conspiracy theories. And over the last 2 years, I've heard many rumors from many people, as I'm sure many of you have, and I'm sure this is generally an open secret, about the the boogeyman specter of our codes being revalued for 2026. And I assume that there's some general sort of awareness about this, which opens up an awful lot of questions of when I started hearing these rumors. It really was 2 years ago. And that tracks from when AMA had gone on to hire Mathematica, which would have been 2023. And that this move here, I suspect, because again, these weird, just total NDA, the non-disclosure agreements, opaque nature of, if you're going to have centralized planning like with the AMA, RUC, and CMS, you can't also have this total information blackout. It's insane. It is literally the mob. If there ever, I've said this word a lot so far in this episode, I'll keep saying it. This is what the Illuminati is thought to be. I don't think the Illuminati is real. I now feel obligated to say that. But if the Illuminati were real, it would operate like this. The only difference is we get to know, we can point at the Illuminati and say, there's the Illuminati. But you have these secret puppet masters, or not even secret. We know who the puppet masters are, but then they just go do puppet master stuff and tell us that we are not allowed to know about it, even though it affects literally everyone, because even if you're not a doctor, you're a patient. Even if you're not all doctors are patients at some point in their lives. So it's crazy, really, to think about. But I suspect that in these medicine Illuminati meetings, that somewhere along the way, it was interpreted or inferred that the fact that you didn't have to peg a physical body to the machine all the time was somehow made our codes less valuable. Now, I could see that. So this was this is what I think it was, from the best of intentions. It was ASTRO's intent to forestall that and bring back the pre-2020 rules to say, look how valuable we are. Now, obviously that was a bad idea, and it was not how you should have argued that. The argument has nothing to do with value and opportunity cost and resource limitation and practice expense. Has nothing to do with the physical body of the physician. So I won't get into this. You go listen to the 17 hours of other stuff I've recorded on this. But if you truly have the ear of people, because there's no radiation oncologist on the 31 panel, and either the 21 CPT code panel people or the 31 RUC panel people, there's no radiation oncologist in any of those. And I don't think there ever has been. I don't know. Fact check me on that. But allegedly we have representatives or liaisons and advisors like other, I think there's like 300 advisors, or whatever term you want to use, argue better. And seeing how some of these people who have told us there are liaisons or advisors or whatnot have acted and argued in the quote unquote town halls, I don't think they had better arguments, just to be really frank about that. And so I think secretly in the background, this was one of the causes of the weird, seemingly out of nowhere push for a return to direct supervision. Which brings us to my favorite. I told you I'd say that an awful lot sarcastically in this episode, the Rocker Mirage. And Rocker was, as I've covered very extensively in other venues and at great length, was a legislative moonshot to take us straight out of Medicare to uniquely pass federal legislation and have us reimbursed through a bundled episodic payment system, still administered by CMS, but just totally out of Medicare, totally off on our own. Never been done before, never been proposed before, just off on our own. And they pitched it to Congress as saving $300 million, and then pitched it to us of saving or making us $400 million, because that works. You can, if you have a pot of money and you promise the people giving you the money that you will save the money, and you turn around and tell the people who are getting the money that they will be getting more money. I was never that great at math, but I don't think the variables even out on that one. And evidently everyone agrees with me, because even though it was introduced to Congress in May of 2024, didn't even get a Congressional Budget Office, a CBO estimate, didn't go to committee, didn't get a vote. It just died with the last Congress, and which is not surprising. You know, that's a crazy lift. Regardless, even if it was a perfect bill, it needs votes, it needs compromise, it needs debate, It needs the literal president of the United States to sign it. And it was glacial. And it certainly wasn't going to save us by 2026, but again, leading to my conspiracy theory that this was known about, these weird changes or this draconian changes. If you read the text of the Rocker bill, it was a breakneck pace of how they wanted to implement this. It was literally, if it passed in the very end of the lame duck Congress, they wanted, it directs the Secretary of Health and Human Services to enact this within 12 months. And there's 2 60-day comment periods. It's literally the most, not only is this unique in terms of this has never been proposed by any specialty in the House of Medicine ever, it also had a timeline of implementation that was faster than anything else ever introduced to Congress in a medical for anything medicine, which maybe I'll do a separate episode on that, but it was incredibly aggressive in terms of timeline. It's just not realistic. And thus we arrive at the entire motivation for making this episode, which is, what are we doing? So more specifically, the weird PPI survey and why I led with that. That was only published on February 15th, 2025. So while it started in 2023 in terms of planning and was conducted throughout 2024, the rest of us mere non-medicine Illuminati mortals only saw it on February 15th, 2025. And you can go to the AMA's website and you can see all these PDFs. So you can see that Mathematica sent a letter to CMS about it. The AMA sent a letter to CMS about it. Mathematica has both the final numbers in terms of the practice expense per hour, but they also have very detailed explanations or descriptions of their methods, as they should. And so within it, you can see that they set out to survey like 100,000, I think it was physicians, or 100,000 physicians or practices, or one of those, but they yada, 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 hand waving smoke signals here, sent the survey out to only 58 radiation oncology practices. And of those 58, they, for whatever reason, only determined that 2 were eligible to collect data for. Only 2. So I guess it's like a clinical trial where out of the 58 possible patients, only 2 met inclusion criteria. Now, the only upside is that 100% of RadOnc practices that were eligible completed it, meaning both 2 did the survey. Then Mathematica said, whoa, the 2, that's not enough data to accurately calculate the practice expense for radiation oncology. Guess we'll just, is there a medical specialty that has a similar name? Aha. Because remember, these are not medical professionals. They're data nerds. So they said, oh, there's this other specialty called radiology. So radiation oncology also starts with RADI. So that's close enough, right? All right, let's just bundle them in there. And that's what they did. Now, I'm going to generously choose to believe that due to the extreme secrecy of the AMA and the RUC, that genuinely no one in radiation oncology knew the nitty gritty. That would be the most generous interpretation of this. Whether or not that's true, I don't know. But so that's insane and that needs to be fought. But what really caught my eye was, so I read this blog post when I got the text. I read the blog post, but I noticed in the blog post that what was lacking was any hyperlinks or cited sources. So where did this come from? If you go read it, you go on ASTRO's blog, you can see they have a nice little table. They tell you about these code deletions and consolidations. Now, normally you would include a link. You would cite your source and you would link. And it was odd. It stood out to me that was not done. So I took to the Googles and quickly found the source data. The source data was from the September 2024 RUC panel meeting. And the PDF that I found was published on October 16th, 2024. And very interestingly, on one of the opening pages of this CPT editorial panel summary of panel actions, there is comment period. And it says right in black and white, if an applicant or other interested party believes an action of the CPT editorial panel was an error, that individual or entity may request reconsideration of the panel action. An interested party is an individual or entity that may potentially be impacted by the panel's decision, regardless of whether they participate in Medicare billing. I cut that part off. And panel actions that are eligible for reconsideration could accept, reject, or postpone. And you could submit this request for reconsideration they give an email for Samantha Ashley, who is the director of the CPD editorial and regulatory services. You can reach out from when this PDF was put online, October 16th, till midnight on November 1st, 2024. And okay, so maybe they tried. Maybe our specialty societies tried, because there's more than just ASTRO. There's also ACRO, who claim to care, are out there campaigning for various titles or whatnot they're doing right now. So you scroll in, and so there's several dozen proposed actions by the CPT panel here. And so you can go and tab number 40 is radiation oncology treatment delivery. And that's where you get what ASTRO is talking about. So tab 40 is the deletion or the combination of the 77402, 7, and 12, and then the deletion of 77014, 385, and 386. And that is where they got that from. And so you see effective date is in the second to last column, but then the final column is request for reconsideration, and it's blank. Now, most of the tabs here are blank in terms of request for reconsideration. And so like tab 39, the one right above that, is for category 3, blah, 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 to cat 1, coronary atherosclerotic plaque assessment. Like, it's a wide range of specialties and codes and stuff. So maybe they just, it's kind of a superfluous thing. But if you keep reading, you find tab 41. Tab 41 is superficial radiation therapy. And that's where you see the accepted addition of codes 77X05, 77X06, 77X07, and 77X08, which are add-on codes to report surface radiation therapy. Also the deletion of 77401, the deletion of 0394T, and the addition of a new heading titled Surface Radiation Therapy, with new guidelines in the radiology section, as well as revision of the radiation treatment delivery guidelines and revision of the radiation management and treatment table in the radiology section to accommodate the new codes, also to take place on January 2026. And under this tab, or in this column for tab 41, we have many, many notes of requesters for reconsideration. So we have Eric Larson, who's a therapist and clinical director for Dermatherapy Solution, asking to include the phrase e.g. electronic brachytherapy in these new surface codes. You have a Dr. Daniel Ladd, who's a board member and treasurer of Dermatology Association of Radiation Therapy, who requests reconsideration of the decision to establish Category 1 codes, blah, blah, blah. Then you have another request from someone named Kukab Hashimi from Electa, and requesting the reconsideration of the inclusion of the phrase, blah, blah, blah. And then you have a Dr. Jonathan Cheng, MD, PhD, DABR, board certified radiation oncologist, also requesting reconsideration. So, that's interesting. So you could submit request for reconsideration in the comment period. It would be included. And, the DermRads crew seemed to know that this was a thing you could do and get a word in edgewise. And so when you read through, and I'm not joking, there's literally dozens of these tabs because again, they do this all the time. It's a pretty common thing. So out of all these changes, there was only 2 other requests that were made besides the DermRads stuff. So you had tab 18, which was the DRE for prostate cancer screening, and tab 19, which was endoscopic sleeve gastro. So, most of these things, just like our IMRT and IGRT codes, most of these things do not have requests for reconsideration. Why? So this doesn't make sense. And so you've got really 2 possibilities, the way I see this. One, because the majority of these codes have no requests for reconsideration lodged, I'm inclined to believe that this is the good old boy network, that only chumps and fools would use this mechanism to submit requests for reconsideration, because the real deals have already been made. The smoky backroom good old boy network, this is already set in stone. So maybe the real people who can get things done know that this is useless. Or maybe the people that have jobs in legacy professional societies to be aware of these things and to monitor these things just totally drop the ball. Because what I would have done if I were running health policy, coding, government billing stuff for large professional societies that collect millions of dollars in revenue each year, I would have tried to organize my community. I would have reached out through emails, X, LinkedIn, Facebook, text, phone calls, face-to-face conversation. I said, hey, this is what's on the table. We have a 2-week comment period. Here's how you comment. Go, please comment. And even if the good old boy network was true, and even if it was useless, at least it was something. Because right now we look, I want to use a lot of different words here, but we look silly. This is absurd. Why did we not try to marshal anything? And I could say to myself, well, Jason, why didn't you do it? Why didn't you know? Well, and in that case, just true. I do forgive myself for not knowing about the CPT panel comment period on these codes. I'm a nerd, but I'm a solo rural radiation medicine hybrid thing. Whatever I do is enough to get me on weird mailing lists for specialties that are not my own. But I can't know it all. But we do pay people, or at least by we, I'm not a member of any specialty society anymore, but there are legacy professional societies that do pay people to know these things and to do these things. And, you know, I've heard through the grapevine that that's also part of where Rocker comes from, is that they just feel like it's too hard to work with CMS at this point. And I would argue that if your solution, because you feel like you can't work with CMS in terms of negotiating, is to propose unique, never been even heard of before legislation to pull you out of Medicare, and it needs the literal president of the literal United States to sign it into law, perhaps there are reorganizations you could pursue before you get to that point. Like, just really take a step back here, because if you honestly think that federal legislation for a carve out for a just radiation oncology in the law is easier than talking with CMS, I think you've got to ask some more soul-searching questions of yourself. Now, fortunately, all hope is not lost. We have I'm going to say it one more time, at least one more time, my favorite thing that ASTRO does, and they have a town hall coming up on March 13th, I think. So it's after I'm recording this, but who knows when you're listening to this. But I don't think they know what the word town hall means or phrase, but whatever. So we'll see what the crew has to say for that. But regardless, for the rest of us, number one, it's possible that CMS does not accept these specific changes. Again, nothing is set in stone. And as we are all very aware, there have been an awful lot of changes at the federal level over the past couple of months and will continue to take place. So who even knows if there will be a CMS to receive these recommendations? There almost certainly will still be a CMS, but it's hard to foresee what is going to happen this year with these sorts of things, given the significant changes that have happened thus far and will continue to happen. But even if they do, by law, the first thing that's going to happen is in the summer, the proposed rules will come out. So we will see precisely what CMS will accept and what that means. And then there will be a comment period, and that will be the time to submit your comments. Just like with the backlash from the supervision, which is a much smaller scale thing, sure, but this is corny to say, but I have no other way to say it, your voice does matter. I obviously believe that, because why in the hell would I be talking into a microphone in my bedroom at 11:50 p.m. on a Tuesday night, is when I'm recording this section? Your voice matters. And so unlike when we dropped the ball for the CPT editorial panel comment section, hammer CMS, hammer them. Do not stop. If these things come to pass as written or are proposed to pass, this is not a time to be a shrinking daisy or violet or wallflower or whatever weird war flower metaphor that's supposed to be. Hammer them. And I would really implore our specialty societies to not pull the rocker game again this year. I get, and again, we can talk about the value of the episode-based payments and all that and whatever. Now is not the time, okay? Because even if it passed this year, it's not feasible. None of this is feasible, right? So even if you were to get that through, this carve out and create a new federal reimbursement system for radiation oncology, that would take several years to do. And if they're going to cut a bunch of codes and then cut our practice expense 40% at the same time, we'll see how many clinics make it to the passage of rocker, the enactment of rocker, whatever. This is not the year to focus on rocker. This is the year to focus on this. And there's been a lot of unforced errors. A lot of people who have very particular interests that are not interests of the specialty as a whole. So the people who are making decisions are generally not in practices or positions that are representative of the majority of radiation oncology practices in the United States, which is part of why I keep doing these podcasts. I would rather be out looking for UFOs or talking about suppressor regulation by quote tweeting Thomas Massey on the internet. That's more fun, but I feel obligated to do these things because I think my practice environment is weirdly intense for other reasons, but it is at least more representative of what I feel like most of us are doing than some of the ivory tower positions that are out there. And your voice matters for all of us. And we're generally a pretty quiet specialty, we'll put it like that. And that has to end. That we have just gotten stomped for 20 years because of that. The combination of being meek and quiet and then letting a few people who have very unique and specific positions call policy shots, that has not worked for 20 years. It cannot continue that way. It has to change. And sticking your neck out isn't fun, which is literally what I'm doing right now, as always. I don't ever enjoy sticking my neck out, but I feel obligated to. And I'm sure my head will get cut off one day, but I'm pretty sure, isn't that how I get into Valhalla? I don't know. We'll see what happens.